Good afternoon or good morning, depending on where you are, and welcome everybody to our next in our webinar series, the PFF response to COVID-19. We're going to cover the current landscape today, and so we're glad to have you all with us. Before we get started, I wanted to let you all know that the slides are available in your control panel for GoToWebinar. If you look under the tab that says Handouts, you can download those there if you would like to. And please feel free to submit any questions that you have under the Questions tab on your control panel as you think of them as we go along. We'll try to address as many of those as we can at the end of our session today. So I'm Amy Case, and I am pleased to be here with you guys today. I would like to extend a very warm welcome to Dr. Ellen Eaton. She's an infectious disease specialist at the University of Alabama in Birmingham. We're so glad to have somebody with infectious disease specialty training with us today, since that's such a focus for our ID colleagues right now, as well as we're joined by Dr. Greg Cosgrove from National Jewish Health and the Chief Medical Officer of the PFF. So welcome, you guys. Thanks for being here.
Thanks, Amy. Thanks for having us again.
So we have a lot to talk about today, and I wanted to just very briefly give a nod to the times that we're living in. If you've tuned into any of our other webinars, or if you've turned on the news or put your head outside lately, we are living in a global pandemic. COVID-19 is a disease caused by the SARS-CoV-2 virus, and it has spread across the world since the beginning of the year, end of last year, and is affecting all parts of our world and our country. We did talk earlier this year about flattening the curve and how important that is. And it seems like we're in a state now where the curve's not so flat anymore. And so now we want to talk about now what? We've been living with this for seems like a really long time. And what do we know, and where do we go from here? So what's happening with these COVID-19 cases? Like I said, didn't we flatten the curve earlier? If you look at these COVID-19 metrics from the COVID Tracking Project and look at that second graph, the daily cases, we see that we across the country came to a peak in April and then flattened things out, and cases decreased across the country in total until in June, when we started to see an increase in those numbers again. We saw that as that initial flattening when we shut things down. We stopped going out. We really focused on social distancing and restricting our movements. And this increase in cases seems to be correlated with reopenings across the country, people increasing their mobility and their exposures to one another. Greg, do you want to make any comments on any of these graphs that we're looking at, what you're seeing there where you are? You mentioned earlier you guys are starting to see a climb in Denver or in Colorado.
Yeah, I think maybe to set the stage, it's what we knew in April is different than what we know now, and decisions made even in May and June. In retrospect, we could have made better decisions, but that is really hindsight in a lot of cases, because we're learning every day the differences in the way in which the virus is affecting individuals and their ability to spread. So it's really disappointing to see the increase in incidence and unfortunately mortality. But I would say it really is such a dynamic or fluid process that as long as we continue to look at things and react and use the science and our knowledge to make sound decisions, I think we can continue to make differences in this disease. But yeah, it really speaks to the power of making decisions, and I think good decisions such as closing down, and we saw the impact. And now what we'll talk about later is the impact that we're seeing with proper face coverings and the importance of that on top of other issues that hopefully we can flatten the curve again or make a significant impact. So as always, we knew this journey was going to be one almost like a roller coaster. We didn't think it would be such a rocky one at times, but I think we can move forward and act, and at least in Colorado, having a mandatory face covering law put in place by our governor, I think shows the seriousness and trying to be proactive, and we'll discuss that a little bit later, the benefits of something as straightforward as face covering for all. So it's an important time to come together, I would say, because we can't do this alone. We have to do it as a community.
So I thought this was an interesting breakdown because if we remember back to the spring, I think we did see a lot of cases around the country earlier in March and April. The hardest hit region at that time, though, was really the Northeast, New York City and New Jersey, and communities in that part of the country. Alan, I wanted to get your input on what we're seeing now and this sort of regional variability in how things are looking in different areas.
Yeah, sure. And thanks so much for having me. What we see now is that the South, and even particularly the Southeast, but the Southwest and border states are really being disproportionately affected by the coronavirus. So as you mentioned early on, we saw New England sites that had a lot of travel, international travel, seeing early cases. And really speaking from the state of Alabama, we were relatively late to see our first case in the state in Alabama in March. However, those of us that are in public health and infectious diseases knew that once we saw coronavirus cases, that we would have kind of the perfect storm for transmission. We know that the Southeast and Southwest and border states have a lot of barriers to access to care. So we know a lot of our residents are over 65. We have a lot of medical comorbidities, including tobacco use related lung disease, heart disease. We have a lot of obesity and the metabolic complications like diabetes, hypertension that go with those conditions. And really those allow coronavirus to really escalate to severe acute respiratory distress. We see patients needing not only hospital care, but intensive care. And we know that these states, Alabama, Mississippi, Georgia, Louisiana, even Texas, a lot of these states have rural community-based healthcare that is not prepared to, for example, care for multiple intubated, ventilated patients that are requiring respiratory support, circulatory support. So really in March, although we didn't see many cases in the Deep South, we were really waiting for, as I mentioned, the perfect storm once our patients were affected due to a lot of those social determinants of health, a lot of vulnerable populations. I didn't even mention, in addition to the elderly, but racial and ethnic minorities were seeing worse outcomes in addition. And we know that a lot of those populations rely on grandparents, extended families living together. So you may have a grandparent caring for a child while mom and dad work. And really, as we think about our bubbles and being able to protect our vulnerable elderly populations from coronavirus, having grandparents or elderly family members that are caregivers is really, unfortunately, a perfect way to transmit coronavirus amongst families, which is what we're seeing a lot now in the Deep South.
Yeah, absolutely. Anecdotally, I was surprised, I guess I shouldn't have been, by the number of family members we're seeing in our own systems that are either multiple of them are sick or multiple of them are hospitalized at the same time. So that certainly highlights the risk of in-home transmission. So I think we've made the case that this is not going away anytime soon, and that it's going to be a problem we're going to live with for probably a while, it seems like. So what are we going to do about that? And we talked previously about the concept of social distancing and limiting our interactions with one another, at least our physical interactions with one another, limiting our exposure to crowds and indoor spaces because of the risk of transmission of the virus, just like Ellen mentioned. And I wanted to bring up and really focus on the idea of face coverings or masks as a recommendation that has come from multiple medical societies, including the CDC, and the reasoning for that, why that's important, why and why we think it's helpful, and how that seems to have changed a little bit since the first time we talked about face coverings and masks and the differences in those recommendations. Greg, do you want to touch on that a little bit, because it is a change. It's been a gradual change, but I think it is a change from what we said early on in our experience in the United States with the coronavirus.
The CDC and World Health Organization certainly have changed their recommendations, and it gets to with enhanced knowledge and understanding of the transmissibility of the virus and the impact of wearing face coverings. And so originally we're taught that a mask is certainly protect the user of that mask. The importance of trying to quell the transmission and reduce the number of infections is really a community priority. And so emerging evidence suggested that I talked about in the blog from several weeks ago, that face coverings strategies in New York City and in Italy dramatically seem to reduce the number of the individuals infected. And then as we've learned a little bit more, and I'm sure Dr. Eaton can comment on this more, the science of transmission, especially in asymptomatic individuals or pre-symptomatic individuals, the knowledge we've gained about the risk of transmitting the virus and the importance of face covering and reducing that risk has evolved. And so I think, excuse me, it's led to a lot of emphasis on everyone doing their part in the community, and that will hopefully move this curve, flatten it, or reduce it significantly, or reduce the consequences of being infected significantly. So I think that leads to the image that we're seeing in front of us. A lot of the PFF staff continue to wear masks at home or face coverings, and it's we're trying to do our part to help the community, and we really need everyone else to do their part and hopefully reduce transmission of the virus. So it's complex, but it's as I tell my patients, it's important when you have a disease that we don't necessarily have a cure for, to take ownership and do things you can to improve your health. And so until we find a cure for PF, we need to do other things to prevent people from getting worse, prevent infections. And taking ownership and wearing a mask, you can help prevent infections in the community, which wraps around to preventing you from getting infected, at least in my mind. Less people have the virus, the less chance you're going to get it. And so it's pretty complex, but I'm excited to see that the science is evolving, and it's driving a lot of the decisions that are being made now, which I think needs to be the case. The experts like Dr. Eaton with her public health experience to guide us in making the best decisions for this week, because science might uncover new ideas next week or the week after, but it's a dynamic process. So that's maybe more long-winded than you wanted.
No, that's great. I pulled in a couple of these infographics from that UAB's put out. I love their Wear a Mask campaign, and I thought it would be appropriate with Dr. Eaton with us today. I wanted to talk about with you, Ellen, how does that facial covering help? And I thought this was illustrative, and Greg sort of alluded to it, but the idea that my mask protects you and your mask protects me. Can you talk about that for us a little bit?
Yeah, absolutely. And I'm so glad you selected this graphic, because I think a lot of the challenge with public health messaging has been that we do not often use language or graphics that are easy to grasp. I love that you did not include specific statistics or numbers, but really the message should be that if you are wearing a mask and you are around someone who is infected, as is demonstrated at the top of your graphic. You know, if, for example, I'm a healthcare worker and I have a mask on, and my patient has coronavirus but perhaps does not have symptoms, it is actually pretty unlikely that I will become infected. And we've even seen that with cloth masks in outpatient clinical settings where our nurses and our staff are using a cloth mask either due to limited PPE or simply because the protocol for someone who is asymptomatic without a fever being seen in clinic is that you just need a cloth mask. We're actually seeing that when that patient then calls us 2 days later and says, my test was positive, our staff is remaining uninfected, which just shows the value of having a face covering on all of our staff and really community contacts, even outside of the healthcare setting. And then similarly, for that individual who maybe had a high-risk contact at work or at the ballpark, or maybe doesn't have a known contact but does develop a fever, we know that if that individual has been wearing a face covering when they were at work, at the store, getting their hair cut, et cetera, it's unlikely that they will have passed coronavirus to their close contacts in the 48 hours preceding their symptoms, if they were really adherent to that face covering. And then you can imagine if we take this from the lessons we've learned from healthcare systems and reports from barbershops where a cosmetologist was maybe infected but wore a cloth face covering, if we take that out to the community, really with your term universal masking, that should be our goal for everyone, that everyone in every personal interaction, specifically when they are within 6 feet, for any amount of time in an indoor setting, the recommendation should be that we're all wearing masks. And I agree, it has been challenging and confusing to just the general public because our messaging has changed. And I would just remind everyone that it's really unprecedented to have something so novel, a virus that we really know nothing about. And we're really trying to respond with public health intervention while learning about it. So in an ideal world, this virus would have entered America with an instruction pamphlet, and we would have known that not only is it spread on on contacts and surfaces, but it was much more readily spread with droplets, and even droplets when someone is talking. It doesn't take singing in a choir to spread this germ. It takes just talking to someone within a closed space without a mask. And if coronavirus had hit the United States with an instruction packet with some warning signs, I think our message from day one would have been masking. But really what we had to go by in the infectious diseases world is other coronaviruses and what we learned from other SARS pandemics. So we knew that it would have the potential to spread on contact surfaces, doorknobs, bathrooms, shared toys and materials in childcare settings. But what we've learned since March is really that is a less likely way to transmit this particular coronavirus. And a much more effective way to transmit it is through shared air, shared space. And I've joked when I've talked to groups, it would be so much easier if this was spread more readily on contact surfaces. We would just bleach things, Lysol things, hand hygiene. It's harder to sterilize space and shared air, right? It's really hard, especially in indoor settings, schools, clinical settings, and then nursing homes, criminal justice settings. To really sterilize the air is much harder than just a bleach or Lysol wipe to everything. And I think that's why we're seeing this challenge. And in hindsight, if we'd have known these things in March, I think you would have seen universal masking advocated and potentially even mandated in many more settings than you are in a delayed and kind of stepwise manner. In fact, as we were getting on this webinar, Alabama's governor extended our mask ordinance. So you're seeing this being rolled out at not only local levels, but state levels as we speak.
That's great.
So
Thank
Ellen,
you.
This is Greg. I wonder if I could pose a question though. With what you just said, would it seem to be important for any type of closed space travel, like air travel, that that masks should be mandated because of the risk you just presented?
Yes, I do recommend that anyone traveling in any kind of public setting, whether it's a bus, a plane, a train, even a car with someone outside of your immediate family, I do recommend a mask. We've seen in the news, I think just one airplane associated coronavirus transmission. I believe I saw this week. I have not looked to tease out the details of that, but you can imagine it's really hard to do contact tracing following air travel. So I don't think we should assume that's the first time coronavirus has been spread related to air travel.
Thanks.
Mm-hmm.
That's a great question. As we're talking, it makes me think back to March and April when the questions were about, should I wear a mask? What's the best type of mask? And the questions were more focused on the mask being protective of the wearer. But this is conceptually very different than that. And it's that the mask is protecting others. And so the importance of a universally masked environment becomes more apparent. And we get a lot of questions at the PFF from our community. And Greg, I'm going to ask your opinion on this. What is the best kind of mask to wear? And what do I do if I don't think I can wear a mask? How do you answer that when those questions come up in your clinic?
I think the best face covering is the one that you wear. And it needs to be comfortable, and it's challenging, especially with different forms of oxygen in the tubing, to keep the mask on your nose and mouth, which is ultimately the best protection to reduce the transmission rate for the community. And so that's what I advocate. And there are so many different forms of face coverings that one can wear. Occasionally patients can't, and especially those who have severe lung disease, anxiety with any face covering can occur. And so what I tell my patients, that if you can't wear a mask or a face covering, then social or physical distancing is, I hate to use the word mandatory, but that is the protection that you can provide to others, but most importantly for yourself as well. And it's hard because we're going on since March and April now for a lot of people changing their lives, but this is a marathon. I think if we can just be safe, protect ourselves until the potentially efficacious therapies are validated, or vaccines are effective and validated, then we can return to normal life. But the implications of getting infected for our community are significant. So I think in the absence of a mask, you really need to limit interactions with others. And that's difficult to say, but it's the right thing to do.
I have one last question on masks. I'm sure everybody's tired of being beaten over the head with facial coverings. But Ellen, give me your thoughts on these masks that I'm seeing advertised every time I open up a browser or my Instagram about that are comfortable because they have valves in them or some sort of one-way breathing, escape route. What are your thoughts on those?
Yeah, so I have seen this question posed as well, specifically from healthcare providers, because I think that early in the rush for N95s, a lot of our community got access to N95 masks that are designed for construction worker. I know that some pipe companies donated many of them, folks that do renovations, et cetera. And the reason those types of workers use this mask is because they have the valve to ventilate so that they don't get too hot and fog up their eye protection or glasses. So it's really a comfort feature, is my understanding, to allow ventilation for the wearer. However, as you can imagine, it does compromise that barrier, and it does allow droplets to be transmitted. So if you have that type of mask, I think you should view it as something that is less protective of those that you are around. I think it's unlikely that droplets would enter through that small vent and infect you, but I think the risk is greater to those in your community that you may be wearing a valve mask around, because when you open that vent, it is really a portal that could allow your droplets, or potentially, we think there may be some potential for airborne spread. Certainly if you coughed or sneezed, you would be able to transmit that through the valve. So if you have that type of mask, I would, avoid using it unless you must. And many of them come with some sort of a valve covering that would contain the droplets, and it would make the mask much more effective, not just for you, but also for preventing transmission to those you're around.
So,
we got a great,
sorry.
We have a great question, maybe something to consider is with this slide, but I'll put it out there and can answer it perhaps. The question is, how will reduced transmission rates help us with our returning to more mobility? So it seems like this might fit with this slide and discussion.
Yeah, that's a great question. I think that has a very heavily epidemiologic answer. Ellen, do you want to try, or should I start and then let you comment?
Whatever you prefer, Amy.
I'll say that. So I'm a mother with young kids, and I think about this type of thing in terms of safety of my children's schools. And so if the transmission community spread and the transmission in the community is very high, the likelihood of encountering a person that is that has COVID-19 and is either asymptomatic or pre-symptomatic is much higher than in the situation where community spread and transmission is much lower. And right now in our state, community transmission is very high. And so the likelihood of putting 25 people in a shared space, I think I saw an estimate. There's a Georgia Tech put together a calculator, and it had something like a 60% probability that somebody in that 25-person gathering would have COVID. And so the lower the community of transmission, the less likely you are to encounter somebody and that person spread the disease to other people. I think the other thing that eases is the ability to identify people that have a disease and then trace the people that they have been in contact with, isolate that person that is infected, catch the people that they've contacted, test them, and limit their contact with the next person so that that point of transmission can be stopped. But when there's so much viral load in a community, that becomes so much harder to do. The work involved, the ability to trace becomes much harder. And I'll pass to Ellen for any additional comments.
Yeah, no, I agree with everything you said. There are some really cool tools that have been developed, and I wish I had looked this up to share with the group, but I think it's Georgia Tech, and I believe this was shared on one of my local news media, al.com today. That's an actual calculator that based on your community spread, if there is a gathering of 10 people or 20 people or 100 people, it will provide some evidence-informed estimation of how many will walk away from that event with coronavirus infection. And you can imagine if your community has stayed home and has very, very slowly opened up and has few cases, a gathering of a larger size would lead to many fewer infections than if a place like Dallas or New Orleans or Birmingham, who are seeing much higher transmission. You can imagine even those small gatherings of like 10 to 20 people, there's a pretty significant number of folks that are going to walk away infected just based on community spread. And then taking that anecdotally, I've been working with a lot of the pediatricians in my area to help develop the safe school policy for our schools and really our county. And what the pediatricians are telling me, kind of to echo what you're saying, is that they're seeing a lot of sick kids, not severely ill, but, you know, cough, fever, clearly infectious, and really any gathering that's happening in the community, whether it's an athletic related event or a birthday party, or a camp, they are seeing cases such that really any gathering in our area at this time is just not safe. And of course, these are gatherings where mask use is not being really adhered to.
I think we can contrast the places in the country, like in the Southeast where we are, with that have high levels of community transmission, with the Northeast, which is currently seeing a real reprieve after their significant efforts at controlling the spread of the virus. And now they have been safely able to, or more safely, I hesitate to say that anything is safe or unsafe. We talk in probabilities and when we talk about this, but they can more confidently open different levels of their community and their economy, and knowing that those transmissions are much lower and the likelihood of encountering somebody who has the virus is much lower, and their ability to trace and things like that is enhanced by doing that. I'm going to leave this topic by just reminding everybody that facial coverings or masks is really in addition to continued practice of physical distancing. And these facial coverings are in addition to or most useful when we can't be at home with our families or separated by significant distance in an outdoor space, but that when we have to get close, we have to be indoors, things like that we should be employing these facial coverings. But it's so important to continue these physical distancing. I love this image. I've shown it before, just thinking about the relative risk of the different activities that we undertake. And if we could keep it super simple and say that if we're outdoors, the risk is lower of encountering, contracting coronavirus. If we're indoors, the risk is higher. Groups are more risky than smaller gatherings. And certainly the best place to be is at home with your family, perhaps wrapped in bubble wrap in your basement or something. So that a little levity there. So just to remember that and remind everybody of those things. So I wanted to transition into some great news. I think since we last spoke to our community here, a few new tools in our toolbox to help us fight COVID-19 illness. This is very busy, and I'm not going to get into the weeds. None of us is going to get into the weeds on these two studies. But I would love to get Ellen, your take, as well as Greg's, on these two studies that have been, and there are others behind them that have been published. One on the use of remdesivir for treatment of COVID-19. This is an in-hospital population. This was from the Act 1 study group, a randomized and placebo-controlled study that did show benefit for hospitalized patients with the antiviral drug remdesivir. And then the recovery study, which this is a UK collaborative group that is looking at multiple interventions for hospitalized patients with COVID-19. And one of those is a steroid called dexamethasone, and use in low dose in this hospitalized population did show some benefit to those also. So I'm just going to open it up. Ellen, can you talk a little bit about remdesivir? And again, without getting too into the weeds about the study, but a little bit about how it's useful and what we know about it.
Yeah, sure. And I promise I will not get too into the weeds because frankly, it's hard for even me to keep up. It's amazing the amount of data coming up on such a broad range of prevention and treatment and public health. So I think I can relate to the audience and probably you and Greg as well, in that it's really just hard to keep up with this constant flow of data. So yeah, remdesivir is one of the antivirals that we have taken from lessons learned from Ebola and applied to large cohorts of hospitalized individuals. So that's important to know. It is not something that's available in the community. It is intravenous. So it's really reserved for those that are hospitalized. And frankly, the clinical trials have enrolled hundreds and hundreds of enrollees, but we're still seeing patients that aren't, and even states that aren't getting as much remdesivir as we'd like to see, frankly, because we don't have other options. So even early on with this drug that's still experimental, it's hard to get. It's hard to get for your sick loved one. And what we saw is a reduction in the number of symptomatic days to recovery. And in those who received remdesivir relative to placebo, on the order of about 4 days, I want to say 15 days to recovery in the placebo relative to about 11-ish with remdesivir. So a slight reduction in the number of days to recovery. However, that was statistically significant, but the mortality data, which we were really hoping to see an improvement in survival with this study, and we saw a trend towards a reduction in deaths, but not a statistically significant reduction in mortality, which was a little disappointing to us because we are still seeing a large percentage of patients. Some hospitals in Alabama, as 20% of patients who end up on the ventilator unfortunately never make it out of the ICU and pass away. So we were really hoping to see that patients would be more likely to survive when they had access to this drug, but we're just unfortunately not seeing that in the current studies. Still hopeful that with additional studies we will see that. We did see, not surprisingly, with dexamethasone, we did see some improvement with dexamethasone in terms of mortality. And dexamethasone is a steroid. So those of us that are physicians were not that surprised by dexamethasone improving respiratory function in severely ill hospitalized individuals. And that's because for those of us that have worked in an ICU setting, we know that there are a range of infectious diseases that will actually show improvement when you provide steroids, which is somewhat counterintuitive. We do get concerned in infectious diseases that when you provide steroids, you take the brake off the immune system and you worry that the infection would then flare up. But what we've actually seen with coronavirus and some other infectious diseases that cause severe respiratory distress is that providing steroids actually puts the brake on inflammation and allows patients to oxygenate. But I should say that it's been referred to as a dirty drug because it does affect the immune system more broadly and does not target the virus itself. There are side effects. So, it is not without risk, but I do think this was encouraging to us. And certainly for those that are on the front lines to just be able to have a tool that can provide some benefit and for families and patients and loved ones to know that there is something actually that can provide some hope. And in talking to, pulmonologists, it was pretty much a light switch. As soon as this paper came out a couple weeks ago, and I'm sure Amy and Greg could speak to this, you started hearing physicians saying, yep, I'm starting folks on dexamethasone, hopeful that I can get these patients off the ventilator, get them home. And you'll probably start to see more of that as this data is disseminated. But I think the overall message is we don't have a silver bullet. These are two pharmacotherapies that have showed some promise. I think you're still going to see more data as we see these drugs rolled out into more observational cohorts. So when we see clinical trials, they are often conducted in an ideal controlled environment with patients who may be excluded due to certain chronic conditions or underlying comorbidities. But what we really care about is, are these drugs going to help our patients that are just regular Joe Smith off the street who maybe has a history of smoking or lung disease, heart disease, diabetes? We want to know if these drugs are going to help our patients who come with a whole host of underlying medical conditions. And that we won't know for some time, as these, it's a novel virus, as we mentioned. It takes time to collect the data, to disseminate the drug, in the case of remdesivir, to get the drug to minority populations, to get the drug to women, to get the drug to pregnant women, to patients with HIV. We really want to know how they work in more real world cohorts and not just in randomized clinical trials.
The comment I might add to your discussion, Ellen, is you alluded to it. The use of any of these medications really is specific. So a lot, since steroids are accessible to a lot of docs, and might jump the gun and say, oh, if anyone is infected with COVID-19, let's give them dexamethasone, and misinterpret the study. It was clear that the benefit was those that had severe respiratory failure and on the ventilator, and there was actually harm in those that had more mild infection. So just like other things in medicine, it's for a very specific group of individuals that maximizes the benefit and minimizes the risk of the medication. So it is great that we have new tools in the box to help those who are the sickest with COVID-19, but we have to be careful not to extrapolate and use them in patients that it actually might hurt. And there's data to prove that it would for the quote unquote average patient who develops COVID-19.
Thank you for clarifying. And also, this is for individuals who have the infection. I know a lot of folks are trying to extrapolate to the preventive side of things. How do I prevent infection? So I appreciate you speaking up, Greg, because it reminded me that I wanted to clarify that for the audience as well.
Well, I've been dealing with steroids and respiratory failure for about 20 years as part of the ARDS study groups. So these questions have been the benefits of steroids in different populations. I'm glad to see that we found one that it's helping individuals again. It's a good tool. We need more of them.
We do. I have a question from the audience.
That might.
Go ahead.
I was going to say there were some questions that came up that are relative to facial protection. One of them is, what about face shields? And if you can't wear a face covering, does a face shield provide adequate protection? And is there evidence to suggest it's a benefit? I haven't specifically looked into that, answer the question. So I don't know if either of you two have information about the use of face shields instead of either face masks or face coverings.
Yeah, I'm happy to speak on that topic. So early on, I think a lot of us were recommending face shields as an alternative to the mask for individuals who are unable to wear a mask, for individuals who work with hearing impaired, where their lips need to be seen. We were hopeful that really over the course of months, we would start to see more observational data of outcomes comparing masks to face shields. We still don't have that data, and for that reason, the CDC does say a face shield is not a substitute for a mask. In fact, in areas with high community spread, the CDC is actually recommending that you wear a mask and a face shield when out in public if your community is really surging. But one thing I just encourage parents, educators, really even my patients to remember is, to Amy's point, the best face covering is the covering you will wear. And a lot of us do view the face shield as a face covering. So I think my professional opinion with the data we have today is that the mask is likely superior based on the data we know. We know that most adults and children can actually wear a mask quite safely, including a lot of folks with underlying lung disease. Certainly speak to your doctor if you're concerned that you may not be able to wear the mask. But we do think the mask, based on what we know today, is superior. However, if your option is a face shield or nothing, certainly you should opt for the face shield. We know that most of the transmission is droplets. speech droplets, and you can imagine really anything that covers the nose and mouth is going to reduce your chances of acquiring infection from droplets. So look for one that has the headband, so there is not a lot of space between the top of the shield and your forehead, and that wraps around and kind of curves towards your ear area so that you are not getting a lot of transmission from the periphery. For example, if somebody's sitting next to you and talking to you, ideally you won't have someone sitting next to you and you'll space out. As Amy mentioned, you know, these face coverings should all be viewed as one part of a combined intervention of public safety measures like distancing and being outdoors, etc. But if you do opt for a face shield without a mask, because you are, as I mentioned, one of those few examples who can't comply with a mask, look for one that has a headband and wraps around to the side, and I would use it in combined with distance and ventilation, outdoor settings, etc. But I don't want parents to be totally rigid with the mask in a learning environment. And I say this for a few examples. If your child has learning disabilities, autism spectrum disorder, schizophrenia, some mental health conditions, children and adults, we know that the masks are really going to be impractical in those settings. So try a face shield, try multiple face shields, try a mask that has the clear, that's one of the clear masks, which I think are so cool, that is technically a mask, but you can see the lips. If your child, I have a 5-year-old, my 5-year-old hopefully is going to go to kindergarten and hopefully is going to learn to read. And I don't imagine that the teacher is going to be able to teach him how to read wearing a mask, where he's really relying on phonetic cues, etc. He has some low-grade hearing deficits. I imagine his teacher will wear a shield and sit in front of a class with plenty of distance and work through their lessons. I think that's going to be really safe, because I know my child will be wearing a mask, and I know that his school is requiring that everyone wear a mask and that they space their chairs. And so those are just a few of the examples where I think a face shield could be considered. Will we ever have studies that show that kindergartners in this situation, who are sitting X feet from their teacher who's wearing a shield, have X% chance of coronavirus? I doubt it. We're just doing the best we can. So I give you a few examples of where I think face shields are probably going to be most practical, not to go against the CDC, who says mask, 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 but just to say these are guidelines, and we also have to be practical and acknowledge that a shield is better than nothing.
Thank you so much.
I have one other question before we leave this, the treatment here, and it was from a patient who said, if I have medications on hand like prednisone, antibiotics, Tamiflu, and oxygen, if I should have symptoms of COVID-19, should I start taking any of them when I have my symptoms start, and would that be advisable?
Amy, do you want me to take that one?
If you want to jump in on that, I just let it hang there for a second, but it's a loaded question.
So my concern is that, and this is a very valid question, and others have had this question and actually done just that. So I don't want anyone to feel ashamed for asking it. But my concern, especially as we enter cold and flu season, is that we want to ensure that our patients are getting diagnosed and getting the right treatment. So for example, I'm worried that we're going to start seeing people with influenza who, maybe have access to prednisone and think, oh, this is probably coronavirus because everyone around me has coronavirus or had a high risk exposure, and start taking a medication they already have on hand. And it's either the wrong infection and perhaps they have influenza or strep throat, or maybe they have a bloodstream infection and that's why they have a fever. And in that case, the prednisone or an antibiotic that's not appropriate could actually lead to significant harm and delays in care. So I actually do not advise this. It's a separate question around, who should be tested, et cetera. So I don't want to get too far out in the weeds, but I think if you have concerns I would reach out to your provider before you do anything and let them kind of talk through your symptoms and your risk factors and think of a plan to address them before you take anything out of the cabinet that you may already have. And really, in terms of outpatient, either prevention or treatment, we don't have, as Greg mentioned, we know these drugs that are effective in a hospital setting when folks are severely ill, but we really don't know what is effective at preventing like community-based coronavirus for folks that do well in the community. We don't know about oral medications, for example, or combinations. So my concern is that you could potentially do more harm than good, either by not having the accurate diagnosis or trying a medication that may potentially lead to harm without any potential for benefit.
That was my thought too, Ellen. And I know you're a public health expert in infectious disease, but I'm going to trump you on this and advocate to perhaps everyone on this call to really remember to get your flu shot coming up for the fall. We should start now, because trying to differentiate flu between coronavirus based on symptoms can be quite difficult. But if you are appropriately vaccinated for influenza, it reduces your risk and also the consequences. So I know the CDC's already started the campaign to make sure that everyone gets vaccinated. But since you mentioned it, I wanted to jump the gun and remind this group that's part of the next step in preventing you. And we have treatments for influenza for specific groups. So I like treating the right diagnosis, the right medicine, and not confusing the issue too much, especially in PF patients. And you commented one thing that raised 2 or 3 patients raised questions. When should at-risk population be tested? So if you do have the subtle symptoms, now when should you be tested for coronavirus? And more importantly, how frequently should you be tested? If you were negative last week and you have a change in symptoms, should you get retested? That's, I think, a pretty insightful question by 2 or 3 of the people on the call today. So Amy or Ellen, if you want to address that, it might be a good time.
I'll answer that for my own experience. It's not personal, but just for patients, is that we are testing individuals or recommending that they get tested if they're symptomatic, even if they're not requiring hospitalization. There are areas of the country, our state in particular, where it can be very challenging to be tested and the turnaround times are very long. But I think that information can be valuable if even if it is a little bit delayed. The thing to remember about that is that if you are tested and something changes, that test was really only valid for the day that it was collected. It doesn't mean that you couldn't next week have had an exposure in the interim and have subsequently been infected. So we do recommend that people who are symptomatic, if they have symptoms that are consistent and or an exposure to someone with COVID-19, that they do self-isolate, even if they're not necessarily ill enough to be in the hospital, so that they don't run the risk of infecting others while they're waiting on that test to come back. Ellen, I'll let you comment also.
Yeah, I agree 100%. So what I've been telling my young patients, young adults, no comorbidities, first of all, the recommendation for everyone is to stay home. If you have any signs or symptoms, or if you've been told that you're in close contact with someone who has now been diagnosed as positive, please stay home. If you are very low risk, meaning you have no underlying medical comorbidities, your symptoms are manageable with Tylenol or ibuprofen and hydration and rest while at home, there's actually not a recommendation from the CDC that you need to be tested, with the caveat that if you, potentially have been sharing a lot of space with vulnerable populations, for example, if you work at a nursing home, then that would be a caveat. But really, if you've been, if you're relatively low risk for adverse complications like severe pneumonia or hospitalization, you can just stay home, manage your symptoms, And the CDC does not feel strongly that you be tested. Now, if you do have underlying comorbidities, I agree with Amy 100%, and this is my message to my patients as well. Because you're at high risk of decompensation, we need to know if you are ill and ultimately require acute care. We need to know if that is from coronavirus or something else. And I'll just give one example. I have a late 50-year-old male with hypertension who had a contact with someone with coronavirus and sure enough developed fever. He was short of breath and we did direct him to the hospital, and I'm glad we did. He had a negative COVID test and was sent home and got worse. Despite antibiotics, went back to the hospital, had 2 additional COVID tests, which were both negative. However, his repeat chest x-ray showed that he had a huge pleural effusion from a likely bacterial pneumonia. And so in him, those diagnostic modalities were really helpful. If they had just operated under the assumption that this was coronavirus, he would not have gotten, appropriate antibiotics and repeat chest x-ray potentially with a procedure to drain that bacterial infection. So that's just one example of someone who looked and smelled like coronavirus, had the right epidemiology and risk factors, but it was really important to get him seen and get him treated rather than sitting it out at home, because certainly he would have continued to worsen at home. So I think that the big differentiation then is the testing should happen if you are at high risk for outcomes due to heart, lung disease, et cetera. And certainly being of an older age or being a vulnerable population, pregnant, for example. In terms of the frequency, so we do know that even the PCRs can be falsely negative for coronavirus in someone who truly has infection. It can be the test result of that nasal swab that you're hearing about. It can be negative 20, 30% of the time, unfortunately, when someone is truly ill. So the message there is if you have signs or symptoms or a high risk exposure, you really need to stay home, even if your test is negative. So I think we've been beating it over everyone's head. If you have a high risk contact, you need to stay home for 2 weeks. And that would even go if your test is negative, because just because it's negative today does not mean it will stay negative tomorrow or the next day. And then if you're a high risk group, your test was initially negative, but everything about your case looks and smells and feels like coronavirus. It would be important to talk to your doctor and discuss if it's worth getting a second coronavirus screening test or diagnostic test. I know some healthcare systems are requiring that they be separated by 72 hours, for example, because they don't want to be retesting multiple people and using those resources when they have first timers who still haven't had access to a test. So your healthcare provider will probably be the one to tell you the best time after a negative test that you would be a candidate for retesting, just based on your local supply of testing resources. And I'm trying to think if there are any other aspects of that question you wanted to know about testing and retesting. And I also would say, in conjunction with testing and retesting, are there other things that you need to be evaluated for? I gave the example of a bacterial pneumonia with a complication, but, could this be something else? Could this be, an unusual presentation of a tick-borne illness? It's the summertime. Could this be a bloodstream infection? We know that fever and muscle pains go with both coronavirus and bloodstream infections, and they're treated very differently. So I think one of the risks that we all run, including myself, is anchoring to coronavirus as the diagnosis 1, 2, and 3 in someone who has a fever or respiratory symptoms in the context of this pandemic. But we all have to remember that common things are common, and bacterial pneumonia is also very, very common, and we need to be very thoughtful when we approach patients who have a negative initial test and keep our differential very broad, because we're still seeing other conditions and infectious diseases in addition to coronavirus.
Thank you so much. We're getting a little low on time, but I do not want to leave this session without talking a little bit about vaccine development, because there have been some really exciting developments in the last week or two on the vaccine front. And I think a lot of us are looking hopefully at vaccine development as our best way out of all this mess, unless our country and the rest of our world gets all of the advantages that, say, New Zealand has at this point. We're probably looking at a vaccine as our best hope for the future. I wanted to get you, Ellen, to talk just briefly about how vaccines work. I think we want to have at least some brief understanding about what a vaccine does to our immune system that helps us when we see an infection.
Yeah, the best analogy I have heard for vaccines is the example of an accessory like a scarf or like a jacket that is very recognizable. If you think of a vaccine, it is like taking a scarf or a jacket that is specific to one person and exposing the body to it, such that the body then says, oh, I know that jacket, that's Ellen's jacket. Whenever I see that jacket, I'm going to know it's Ellen, and I'm going to respond to Ellen because Ellen wears that jacket. So similarly, you can imagine a vaccine takes a part, a protein, an aspect of a virus or bacteria, and introduces it to your body such that your body develops a response. Your body doesn't have to see Ellen in the flesh to know that's Ellen, but your body saw some aspect that is not harmful, right? We don't want to inject harmful toxins into an individual. We want to inject just enough information that the body says, aha, that is COVID-19. I need to respond appropriately. And the goal is that that vaccine generates antibodies and what we call cellular immunity, which is a whole host of proteins and immune responses, such that it can effectively respond and prevent that virus from actually infecting our cells, infecting our bodies, and making us ill. So what you're probably hearing about in the press is various proteins, various, for example, I think a lot of the lay press has described spike proteins as one of the targets that we're using in terms of vaccine developments, taking these proteins that are unique to coronavirus 19 and exposing them or introducing them into the body. So the body develops antibodies and immune responses that can attack coronavirus if and when our bodies are exposed to it. So again, just to summarize, we use this, we use a vaccine to kind of manipulate the immune system. We expose something that is safe for the body, but similar enough to the real pathogenic virus that we can recognize it and mount antibodies, ideally neutralizing antibodies that can just stop the virus in its track and generate these other immune responses such that the virus cannot enter any of our cells or infect our bodies. And, you know, I think there's a lot out there about vaccines, about the specific ones that we think are going to be more effective, about really billions of NIH dollars that are being used to rapidly test these vaccines that are thought to be the most potentially effective candidates and get them out, because the goal is to really get these vaccines out as soon as possible to prevent any more tragedy from this pandemic.
That was a great, I've never heard that type of analogy before, but that's really helpful. I think I'll use that in the future. I wanted to just remind everybody about how drugs, vaccines, and other types of medications get through the research and approval process. I think our community is very familiar with this. Many of us are familiar with this because we've watched very eagerly the development of therapies for pulmonary fibrosis. And so we know that preclinical testing, so in animal models or sort of, I explain like animal models or test tubes or something like that in a lab, we do preclinical testing to try and identify candidates for medications, in this case, a vaccine for COVID-19, and see if it has a rationale, a scientific rationale, and see if it makes sense. Does it meet those preclinical requirements? Then we go through phase 1, 2, and 3 studies before a medication, or in this case, a vaccine, can be approved. And those different phases are focused on different things. Number 1 is safety. We have to make sure before we start exposing larger numbers of people to these therapies that they are safe. And so safety is paramount. Dose finding is another early aspect of the earlier phases of research and testing and development. And what is the appropriate dose? What dose, in this case of a vaccine, and are repeated doses necessary to elicit the type of immune response that would protect a person? And so in this case, we've got therapies that are in earlier phases, and what we're seeing is that we've heard now that there are candidates that are able to, in small groups of people, elicit an immune response that we think will be protective and effective. But now we're moving into, with some of these vaccine candidates, phase 2 and 3 studies, where large numbers of people, thousands and tens of thousands of people, will be included and enrolled. And some of them will get the vaccine candidates. Some of them will get placebos, and they will go out into their communities and live their regular lives. And we will then watch to see if those people get COVID-19, and if the group of patients that got the vaccine are more or less likely, hopefully in this case much less likely, to contract COVID-19, that will prove the efficacy of one of these, or more, hopefully, of these vaccine candidates. But all of our therapies go through these different phases. And so I think it's a good reminder just of the process as we're talking about vaccines, but also applicable to pulmonary fibrosis drug development as well. I also want to bring up, I think it's so interesting that in the race to a vaccine, that so much is being done to change the time to effective vaccine development. This is an image from the New York Times. It's an opinion piece, but it's on their opinion page, but it's an interactive, and you can click different aspects of the development and see how that changes the time to access to a vaccine. In a traditional model, it would take into the 2030s for people to have access to a coronavirus vaccine. But there are lots of things that are being done to try and shorten that time course. And Ellen and Greg, both of you, please, Ellen first, to comment on what you're seeing happening with this vaccine development that's hopefully going to change the landscape for us.
Yeah, I'm hopeful that we know now we're enrolling for phase 3 in coming weeks, and you may have seen ads for enrollment requesting participants. I'm hopeful that we'll start to see benefits as we approach 2021, and that we can focus on dissemination if and when it's shown that the candidate vaccines are effective with minimal side effects, and that we can then turn our attention to getting folks into the clinic, disseminating these vaccines. And I do know that there are panels at the NIH and National Academy of Medicine who are focused on the ethics and dissemination to vulnerable population, with an emphasis on those who are likely to do very poorly if they get infected with coronavirus. So I think a lot of those discussions are happening now, how to target not necessarily the young and healthy, but those that we're concerned will end up on a ventilator if they don't have access rapidly to these vaccines. So that's really my perspective, and I know that's in talking with a lot of my ID colleagues, that's our hope for the next few months.
I think maybe the other comment to make as to why you can go from 13 years down to 13 months perhaps is, rather than having a sequential process that was outlined, it's been mentioned in some of the press, but the vast majority of therapies for COVID-19, there is parallel courses with at-risk production. And what that means is if you look at the candidates that are going into phase 3, they've begun producing the vaccine anticipating that it will be proven safe and effective, so that the moment it is proven to be safe and effective, they have significant quantities to begin dispersing it rather than waiting for approval and then starting to mass produce the vaccines. It is certainly not the process that's typically undertaken because the risk if it doesn't succeed or not. But given the priority for our nation and support from the NIH and other companies, they're certainly looking how important it will be to bring this vaccine to the world. So for me, thinking about the impact of COVID-19 on drug development, the coordination and the breaking down of barriers to rapidly identify a safe and effective product is unheard of. Maybe the only other time I've seen it in my career has to do with therapies for HIV, where they were rapidly evaluated and then utilized in patients. Probably taught us a lesson that we can do things more efficiently and faster and do them with safe and appropriate evaluations. I think back to Dr. Collins' interview last week, where he really emphasized we're doing everything as fast as possible, but the safety is being maintained. And so we're not compromising safety to evaluate the vaccines. We're just reducing the barriers in every other way possible so that we can bring it to bear as soon as possible. So that's pretty exciting. I wish it was tomorrow. Sure, everyone else does.
Right.
But it's really, now is the time we're all, hopefully crossing our fingers and toes that any of the trials can prove that it's safe and also effective as soon as possible. And the volunteerism, I imagine, Ellen and Amy, I'm getting calls every day. How do I volunteer for a trial and a vaccine trial? I find that highly encouraging. The more people that volunteer and do it quickly, we get to the answer as fast as possible, so everyone can benefit. So it's an exciting time, but the pandemic is necessitating a revolution in drug development.
Absolutely. Well, that is going to wrap up the content I have for us. And I know we've sprinkled some of our listeners' questions throughout here. So hopefully we've gotten to them. If we have any follow-up, we can try to do that electronically by email. I do want to make sure that everybody is reminded that we have COVID-19 specific resources on the PFF website. They're all there together. You can link to them from the homepage. And we are constantly updating those so that they're current and vetted and reliable. So please check those out if you haven't had an opportunity to do so. This webinar will be posted later, so that if you want to go back and view it or share it with anyone else, then you'll be able to do so then also. And I just wanted to thank Greg and Ellen again. Thank you all for being here today. This has been a really great discussion. I always feel like I learned stuff from these webinars myself too. So thank you. Really appreciate it. And you guys have a great and wonderful rest of your day.
Thank you.
Thank you, Ellen. Thank you, everyone, for attending. And thank you, Amy, as always.
Thank you. Bye, everyone.